you know what, oh, thank you for that reminder. Let me do this, and then I think I need to change. Okay, can you guys see my slide? Great, I'm seeing thumbs up. Okay, good afternoon. Thanks so much for sitting in on this afternoon presentation. My plan is to talk about ethics about twice a year. This presentation will repeat some of the core concepts that we reviewed last fall. I wanted to review them here today for any kind of newer ECHO members that recently joined us. However, it was probably about a month or two ago, I reached out to the community to get an idea of what are some ethical dilemmas that folks have faced over the last couple months. And so those are going to be the sort of specific ethical issues that I reviewed today. And so that'll be my plan kind of each time I present on ethics. We'll talk about the basis of ethics kind of stays the same, but I really like to hear what are the specific dilemmas that folks are facing. And I got some great suggestions. So thank you guys so much for what you shared. Just a reminder, anytime I give a presentation, it is a requirement on my farm animals to make appearances. That's how they earn their keep. Sometimes I'm able to get it to make sense with the slide that I'm presenting, and sometimes it makes no sense. Here's a perfect example. And then also a quick thanks to Laura Lander. She was the original creator of a few of the slides I'm going to be sharing today. So the field of ethics involves developing, defending, and then recommending concepts of right and wrong behavior. Ethics deals with us humans' well-being, and it looks at the nature of individual good and then the nature of social good and the relationship between those two. The ethical motives that really exist for the individual to pursue social good and or what is morally right. And then the relationship between pleasure and good. And then for us in modern ethics, this is really about recognizing what our duty and moral obligation is. Thankfully, the ethical code does change over time in response to how our society is changing, which then affects how our laws change, and it's going to affect how our training is changing and how we're just changing in general. So each of us here in this Zoom room, we've got our own separate professional ethical code that we're required to follow. And so because of that, it's on all of us individually to really know what our ethical code is, to understand the principles, and also understand sort of how our personal values end up falling in line with the code that you're assigned to. Because sometimes what happens is your values may not align with what your professional ethics are, and so what do? I gave an example, this is a made-up example. So it's in my ethics to respect my patient's right to privacy and confidentiality. But let's say I'm driving down a dark country road late at night with my husband, and I happen to see my patient pulled off on the side of the road with a flat tire and a very distressed look. You know, what do? How do I respect that patient's privacy and confidentiality, but also respect their safety? How do I best help them if I think that there's sort of two levels of ethics that are at play with each other? There's several different ethical codes I could talk about this afternoon: social work, psychology, etc. I'm going to end up referencing NADAC and ACA the most. So NADAC's the Association for Addiction Professionals, and then ACA is the American Counseling Association. So I'll read NADAC's definition here. So ethics are generally regarded as the standards that govern the conduct of a person. Smith and Hodges define ethics as a human reflecting self-consciously on the act of being a moral being. And so this does imply a process of self-reflection and awareness of how to behave as a moral being. Some definitions are dictated by law, individual belief systems, religion, or a mixture of all three of these. And so what I find, one of the aspects of this definition that can be challenging is that word moral, because so many things, including the laws we abide by, our own individual belief systems, and then our religious viewpoints can really alter our perception about what we believe is moral. So for an example, to me, the abortion debate is an example of this. Depending where you fall on that, you feel very strongly about your moral code, whether you are pro-life or pro-choice. And so how do we apply our assigned ethical principles and standards to our work practice? And how do we provide quality treatment in an ethical way? I was trying to find a way to make this picture an example of ethical practice, and I just can't. I just wanted to share. So we need a foundation to our healthy ethical practice, and we obtain that by honoring these 4 keys. So key one is recognizing your strengths and limitations. This requires you to complete really an in-depth exploration of your own baseline from kind of a personal basis and a professional basis. Key two is respecting the tier of ethics. So this requires you to understand and abide by the different entities or ethical tiers that influence our decision-making, and we'll talk more about that in the next slide. Key three is all about seeking continuous learning. So it's exactly what we're doing right now. It's this opportunity we give ourselves to expand our knowledge base on all aspects of being a helping professional. And then key four is making the rules. So this is all about establishing that norm of behavior against what exceptions may occur. So when we're in the process of making an ethical decision, we get guidance from each of these tiers. So tier one is the federal level. This is the highest tier. It includes federal statutes that must be carried out by all states. Tier two is the state level. So this tier is informed by federal requirements, but can often include directives on how to carry out federal laws as well as additional laws. Tier three is the licensure or credentialing level. So we have mandates from credentialing boards and professional organizations that we have to abide by. Tier four is the agency level. So there's going to be rules and standards in any agency's policy and procedures manual, or maybe an employee publication manual that you have. And then tier five is that personal level. So each of us in here, we have our own internal ethical codes and morals. And that's really created by our personality, our observations, our life experiences, and then what our goals are. So what is an ethical dilemma? It's a challenging situation in which it's difficult to decide on the most appropriate or most ethical course of action. So oftentimes in these situations, you're going to have ethical principles at odds with each other, potentially multiple at one time. And so in order to meet the needs of one, you may end up having to compromise another one. And I think in these situations, it's difficult because it's not necessarily possible to make the absolute right or correct decision. It's really more about making just the best decision you can in the moment, given the circumstances. So here I am having to decide whether to feed my dogs or chickens first. It was a true dilemma. I decided to go with just feeding both at the exact same time. So when we're faced with an ethical dilemma, we really can benefit from the guidance of a decision-making model. This model is a culmination of steps from actually a couple of different models out there. So we can review them together. The very first one is to seek consultation or supervision. You know, we want to remind ourselves that we don't have to make these tough decisions on our own. If you work for an agency, hopefully the hope is you've got a supervisor or a professional colleague or agency management that you can go to. Step two is to clearly define the ethical dilemma issue. What are the parameters of the dilemma? Think about the who, the what, the where, the why. Reflect on what's the impact of that decision going to be on the client, on you as the provider, on the agency and larger systems. Number three, identify the ethical standards pertaining to the issues. So doing this can really, really inform your dilemma, and then also the direction for kind of deciding the course of action. You want to make sure you're reading through your codes and picking out the ones that are at play here. Four is identify your agency policies and maybe any legal issues pertaining to the issue. So again, the hope is your agency should have a policy and procedural manual, and or your agency may have legal consultation available to you. Number five is identify any cultural issues involved in the case, both from the client perspective and then the tiers perspective. Six is revise the definition of the dilemma as needed. So once you end up reviewing the ethical standards and the policies and procedures, you may end up viewing it a little differently. In fact, some of it may end up sort of solving the issue for you. Number seven is identify possible options using, again, the support of your support team. That's what they're there for. And then developing an appropriate ethical response based on all the steps that you have gone through, and then making sure always that we're documenting. So last fall, when we reached out to the community and kind of picked just a couple of ethical dilemmas to focus on, if you remember at that point, we talked about boundaries, self-care, and telehealth. And so this time around, based on some great suggestions, we're going to talk about treating family members, remembering our scope of practice in advocacy. So let's talk about treating family members. Many of you are probably providing services in small towns, and you may in fact be the only service provider available to your patients. So how do we best treat family members while we're also honoring our ethical code? The great Dr. Bruce Gorby, I don't know if he's joined us yet, he brought this ethical dilemma to my attention by way of his own case example. So he said that their agency have some couples who drive the distance to get to their program. They only have one vehicle and one or both of them work. They depend on each other to get to treatment, and they indicate it's necessary that they're in the same group. The dilemma that we recognize are the pitfalls of what could happen if they're in the same group, but also what happens if that couple doesn't seek treatment because of this obstacle. So there's several ethical principles that are at odds with each other here. And so we'll just kind of name a few here to get it started. So the first one is justice, right? We want each of these patients to have fair access to quality treatment. We're dealing with a conflict of interest here. If we're working with both of these family members in a group setting, we may find ourselves in a place where we want to instruct one family member to do something that could potentially negatively impact the other family member. So what do we do when that happens? Obviously, confidentiality is an issue here. You could argue that by coming into the same group, the family members are foregoing their right to confidentiality. But the issue that I see with that is that the perspective they have on their first day of treatment when they're trying to get into treatment and they will agree to anything just to be able to access help, that could potentially change over time. That could also change based on the relationship that they have with that family member. So I think I'll sort of hand it over to you all as a community. Where could this potentially go wrong, having a couple in the same therapy group? Maybe let me stop sharing my slides. Maybe. Thoughts from you all. What do you see as the pitfalls of having couples or really any family members in the same group?
Mr. Chat said they divorce.
Yes, exactly. What happens when they are in love when they first come into your group and they're in hate halfway through? Yes, great point. What are other issues?
If there's any safety issues, they wouldn't feel free to discuss it.
Yes, Laura, that's one. There's so many reasons this is a big concern to me. That's a huge concern I see, is if there's any potential domestic violence, and group could be the place where they could talk about it with each other. But if there's safety concerns, then absolutely they're not going to. Mary just added, yeah, they're not going to talk in front of each other. If there's a safety issue, or maybe if there isn't a safety issue, then they still may just not feel comfortable talking about certain things. What are some other potential problems why this is an issue?
One is more committed to recovery than the other.
Yeah, Jennifer, I totally agree with you. I think that's where, and it's hard to be able to provide one patient, I think, guidance or support about making tough choices in their relationship if the other half of their relationship is in group. Many, many moons ago, it's been a long time, there were a couple of situations where couples were sort of grandfathered into our clinic because we had acquired them from another one, and we had couples in a group long enough to realize it was just not a good idea. And one thing that I would encounter is there was often one member that wanted to speak for the other one a lot, and that became a problem. Any other thoughts? All great suggestions, thank you. Okay. Oh no, I have to go reshare my slide. Okay, can you guys see that? Whew, okay. Yep, so really the general consensus from you all is, I hear and honor Dr. Gorby's struggle with that, about wanting to provide good care and not wanting one patient to be left out. But to me, the potential damage from that is just too great a risk. And hopefully now, because we've got, we have virtual options for folks, maybe it's okay, one patient attends his clinic, and the other patient can maybe access some other virtual care that's going throughout the state. Well, that was a great general consensus from the group. Let's switch over to talk about scope of practice. So I'm probably biased, but I think the addiction field is one of the best fields to work in as a clinical therapist, because we often get to work alongside a multidisciplinary treatment team. You know, I see that as we have the opportunity to learn so much about, like, you know, the medical side of things and the medication side of treatment. I've heard that feedback from other therapists and also peer recovery coaches. They love to, you know, blend their own personal experience of recovery with the clinical skill sets that they're gaining in their training and just being on the job. But for all the great work I've seen us therapists and counselors do, I think the area I've seen us go astray the most from is this topic of medications for opioid use disorder. So it's a reminder that what we can do as these professionals is, you know, recognize that a patient meets their criteria for opioid use disorder. We can educate them on the evidence-based treatment aspects of medication-assisted treatment. We can educate them on the mechanics of the medications for opioid use disorder that we learn about in these echo sessions. It's not our place, however, to instruct our patients on dosage changes, and it's definitely not within our scope of practice, really, to share our opinion with them on when we think patients should be stopping the medication. So, for example, if a patient's asking me, you know, what's the difference between Suboxone and Subutex, absolutely I can educate them on that. If a patient is telling me they've noticed maybe they have blisters under their tongue because they put their strip in the exact same place every time, you know, it's okay for me to suggest they move it to another place under their tongue, provided I've kind of run that by their medical provider first, and making sure I'm checking in with them. But let's say a patient's telling me that they've just celebrated their 1 year of sobriety and they've found a stable place. It's not my place to say, well, then, you know, let's start talking about your tapering plan. You know, you've gotten this place of sobriety. I think you're ready to get off the medication. That would be me sharing a personal opinion, and a personal opinion that's not backed by evidence. And so when I asked the group for ethical dilemmas to process today, Dr. Kristen Clancy from Texas, she shared that she had been reading in an ASAM mailing regarding the concept of intermittent dosing of Suboxone for a patient that wants to continue to use sometimes. And so since this is not in my scope of practice, I'm going to pass this over to Dr. Husted, who I checked with ahead of time. Dr. Husted, did you get that mailing, or is that something that you have heard of?
I haven't got the mailing, and I'm glad that I'm still on video because I almost forgot that I agreed to do that. Yeah, I think it's kind of crazy personally.
Yeah.
You know, it's treating Suboxone as a drug and not as a medication. I mean, there are some medicines that you kind of take as needed for things, but it seems so strange. It's kind of, you know, as much as we don't like to go into too much absolutes and want to work, you absolutely have to decide, are you going to take medicine or not taking medicine? I guess the only place I would see maybe a role for it was somebody who's just starting out in recovery, and it's kind of like, okay, you can't get them to fully commit one way or the other.
Mm-hmm.
And maybe it's like, okay, we'd rather you taking this medicine than using a drug. And if you're ready for you know, to enter treatment, you've kind of tried it. But for somebody long-term who's been in treatment and just say, well, I'll prescribe you Suboxone sometimes, you can do drugs at other times. Mm-hmm. To me, that I ethically, I don't think I could do that. I guess there is a school of thought too, though, that if somebody is going to use, you know, this was something that's discussed. It's not something we've really discussed in Echo, but I guess this is a safe place to a degree. But if somebody's going to say inject a drug, would you rather them inject something that you know what it is and it's not going to cause as much harm compared to fentanyl, say? So I can understand it's easy to kind of go down that rabbit hole and start going to really kind of murky ethical waters. But personally, I wouldn't prescribe like that. So.
Sure. And you know, and I apologize, when you started talking, I should have stopped sharing my screen. I don't see Dr. Clancy on the call. Any follow-up thoughts to what Dr. Husted is sharing? Is that?
I agree. It sounds like a really bad idea to just take the Suboxone whenever and then use at other times. It sounds like a setup for an overdose.
Yeah.
because,
Yeah.
you know, what's going on with your tolerance, what's going on with your receptors. So,
Yeah.
and yeah, I mean, it works as medication, but you got to take it all the time.
Right.
So, yeah.
I think I think we miss the most important part if we do it that way, because basically the way MOED works is because patient also gets behavioral therapy, behavioral treatment. The most important part, I think I mean, we have our outcome studies of our co-clinic. We understand that it's the structure, it's a combination. It's not just the medicine itself. Well, on the other hand, think about college students using stimulants, Adderall for exams. So use it as a study pill. So I used to work at student mental health and treat a lot of students. Actually, majority of students they just use it that way. So, but on the other hand, you know, the question is, do they really need medicine? Do they really, I mean, we understand 8% of kids have ADHD, 4% of people carried over to adulthood. And so college students, we're talking about probably more than 4% of college students still have ADHD, but does everybody need Adderall? Does everybody need a stimulant? So that is a question. I guess what I'm trying to say is that, so if it's a medicine, if we know how the medication works on our brain to help us not only just for cravings, it's also trying to reset the threshold, reset the pleasure threshold to help patients, regain the ability to enjoy things. That is, on top of that, try to retrain the frontal lobe to regain control with behavioral therapy. So I guess that kind of use is definitely not really scientific. So, but their place is just let people use they're gonna overdose and die. And so what are we gonna do? So we're gonna let them use here. We set up centers for them to use, so control and monitor the use is safer. So we still, I guess we still have a lot of unknowns, but no matter what, I guess FDA has has indication for maintenance use, basically to use it every day. So that's what we're supposed to follow.
Thank you, Dr. Zhang and Dr. Reynolds and Dr. Husted. Appreciate it. Any other thoughts on that?
I guess the only other thing I would say is if we start doing things like this, like where we, we say, okay, yeah, we're going to prescribe it just as needed, and here, take it, and you can continue to use drugs. That does not go over very well with a lot of people. Okay, if we already have difficulty people accepting the use of medications, they'll definitely not accept it then. And especially law enforcement, like if law enforcement or something gets wind of that, you're just setting people up for failure. So not that everything should be determined by the optics of it or what it looks, but it is a reality. And I think sometimes when we like discount some of the experiences that law enforcement have had, and where we kind of poo-poo things and say, Suboxone is not misused or diverted or anything, that's really disingenuous, and it's not really the truth, because their experiences are just as valid as what we experience. So just keeping that in mind, that we have to kind of balance treating people but also society.
Yeah.
It's also my concern. It's also my concern in some of my co-clinic patients. They're not really doing well. I don't think they're taking Suboxone appropriately. I don't think they're really engaged in behavior treatment. So most of them probably just use Suboxone like, sporadically. They pass the urine tests, then they really, but in the meantime, they continue to use other, drugs. So that's my concern. And that's my theory as well. Always trying to figure out how to help these patients. Hopefully we can profile patients. We know so how to help them.
Dr. Zhang, we cannot take Suboxone as needed. The receptors either they need it or not. It's like for internal medicine, you cannot take diabetes medications one time and one time you cannot take it. Also for blood pressure medication, either you have to take it every day or you don't need it.
Such a good point.
The other issue.
That's true. That's for exactly for ADHD treatment, because basically we do give them like a drug holidays, try to help them with tolerance. But in the meantime, if they don't take it every day, they probably don't need it. at all. So
No.
for college students, so why do you? So that's my question as well. So basically, take it as needed is not really appropriate.
No.
Yeah. Mhm.
Yeah, the other issue that comes up is that Suboxone has a street value. And so a patient may use their Suboxone to finance their drug use. And so we do pill counts and try to catch people who are diverting their medication for the benefit of acquiring drugs to use. And so the outcome, when you measure outcome, it's not just abstinence that we're after, but a quality of life and functioning. So you need to kind of think of the big picture and not just focus on whether they're positive or negative for a drug screen.
Oh, folks, all good points and all good reminders. I'm sad that Dr. Clancy's not on here to hear it, so I'll make sure to pass this back over to her. Thank you, guys. One more key point and then some finishing up comments. Did I do it right? Can you see my slides? Yay. Okay. Oh, except you're not advancing. Oh, here we go. Okay, so finally, let's talk about advocacy. So advocacy is a requirement both within the NADAC and ACA code of ethics. The ACA code, in case you're interested, it's A-7-A. It reads, when appropriate, counselors advocate at individual, group, institutional, and societal levels to address potential barriers and obstacles that inhibit access and/or growth and development of clients. So again, this is where I asked the community for examples on ethical dilemmas, and it was Dr. Clancy again who shared this. I work in Texas. Less than 50% of community pharmacies will dispense buprenorphine for opioid use disorder, and less than 40% indicated that they would be willing to do so. How can we address this from an ethical standpoint? And so I will put this out to you all. Is this an issue for you in your communities? Have you found any success with any particular advocacy strategies? And then what recommendations would you give, Dr. Clancy?
That's as primitive as not dispensing birth control, because you're Catholic and don't believe that people should use birth control. And that's terrible. That something needs to be done about that.
Yeah.
This is Texas we're talking about. It's rather primitive there. So,
any of our folks that come from maybe smaller communities across West Virginia that have struggled with this with your pharmacies?
The only time that I have had this be an issue was when we had a patient that was actually, she was hospitalized at Summersville Hospital, and we had to end up taking her prescription of Suboxone. She was in the ICU, and they wouldn't give her any Suboxone.
The hospital wouldn't administer it.
The pharmacy wouldn't order it. Yeah. So
did they have it on formulary at the hospital? Because that's something we've encountered.
I'm not sure. I'm not sure.
It's
a WVU hospital, so I don't know if it would be any different than the other pharmacies.
How recent was this?
It was at least a year ago.
Okay, if that ever happens again, we get on the phone with our people.
That was the past summer. It was this past summer.
She had her second heart surgery and was in the hospital.
After
and
that,
then it was after that.
Yeah, you're right. Okay. So this past summer.
It was more like towards the fall, but yeah.
We have had some other pharmacies too, like well, that was a while back whenever the pharmacies, like they weren't established with the patient, then they wouldn't fill their Suboxone.
Mm-hmm.
Yeah, I've had multiple issues, just even down here where pharmacies either they only take so many patients, and because they can only order so much, and other pharmacies you just won't fill it at all.
Mm-hmm.
So it has been a problem. A lot of patients that I see come from smaller rural areas, and it can be a big problem, actually.
Yeah.
Well, I had an issue with like Walgreens. Like I had sent prescriptions over for Walgreens and wasn't notified till later that they were out, but I couldn't just transfer them to the Walgreens across the street.
Mm-hmm.
All new scripts had to be sent in. It was a big mess, and I struggle with that issue a lot.
Yeah. Sarah, that's a great example of great advocacy of, you all literally brought the medication to the patient in the hospital, communicating to the hospital, this is how important we think this is, and this is how important we think it is for the patient to receive this.
Yeah, we might have busted through some boundaries there on that one, but yeah.
Sometimes that's what you have to do with advocacy, right? It's about kind of what's best for the patient.
Yeah. And she was well known to us. Like she had been in the program for over a year and done well. So
we used to have problems where rogue pharmacists, not just pharmacies, but rogue pharmacists would choose not to fill a prescription. So the pharmacy, they were established patients, and the pharmacist would just flat out refuse to fill. We had that one time with a pregnant patient when I was on call as a resident. So a pregnant patient was getting her Suboxone. It was the dual product, and the pharmacist refused to fill. And I actually talked to the pharmacist for like half an hour trying to convince him. He was just a scab pharmacist filling in, but he refused to fill. So it got to the point, and he put the lady into withdrawal. Thankfully, she was able to get it like a couple of days later, but he endangered her life. He endangered her unborn child's life. So I reported him to the board of the pharmacy. And he went before a state inquiry, but they didn't do anything about it, but it probably scared the hell out of him. So I don't think he ever withheld from it again. So sometimes you do have to, somebody is that malignant and not following
that's a good
through.
point.
Yeah. So yeah, don't feel bad to do that. And sometimes it's exactly what needs to be done. So.
Yeah. Another example of advocacy, right? If our patients are fearful of kind of raising their own voices or their own message about it, if we can do that for them, and if it's by way of kind of proper reporting, that's a great example. On the one hand, we hate when it has to come to it, but if that's what we need to do to make change, that's what we got to do.
So my question is, I luckily it doesn't happen very often, but some pharmacists are not really, they're reluctant or they refuse to fill the prescriptions. So the question is why? So what's going on? So we need to, I guess communication is very important. Dr. Jackson, Ben Jackson was a previous fellow. We did a QI project. We basically drafted a letter. Also, we have a diagram, explaining clearly, describing the structure of the code clinic. So we have a step, group-based, stepwise structure. We see patients, less often with time going on and longer into recovery. So we have a very good diagram explaining the structure of the program, how responsible we are. So I guess the question is, a lot of times because patients abuse drugs, or maybe there's sometimes that we have some individuals abuses pharmacies or the system. So it causes that kind of negative image. So we have to think about ourselves, what kind of roles we played. I mean, some providers probably are not using like a structured program to help patients as well. So I in this kind of case, I always try to think more about how to solve the problem. So I guess it's a very good QI project. Also, or in the future, hopefully we can communicate better with the pharmacists. So it's just like what we are doing with Katie, Laura. Remember, what are we doing with the judicial system? So we understand each other after 12 weeks, 12 sessions or whatever. So we know, because we all see we see different sides of the coin, right? Because we see them as patients, but the judicial system, the judge see them as very differently. So I'm pretty sure that we all try to help them. But again, the question is that how to understand each other better. So that's more important. Yeah.
That's a great suggestion, Dr. Zhang. If there's some sort of kind of specialized echo sessions that we could have for, if it's pharmacists across the state or the pharmacy board or something like that. That's a wonderful idea.
I mean, I think a lot of these things come down to building relationships. Having that connection with people. I mean, if we go in and tell somebody, well, you're doing it wrong, like we're not going to be very impactful. so it's really about building relationships, and, bringing pharmacists on board would be great, so that they can kind of talk to their own, their people, talk to their people. I had a flip situation of this where I had a pharmacist get in touch with me and tell me that my patient had been arrested for diverting his Suboxone. And so they didn't want to fill it. And I was like, yeah, thank you. So they were also looking out. So, I mean, they are looking out for the proper use of medication. I think it's really about that conversation of, okay, well, like the reasons why, like Dr. Zhang was saying.
Yeah. It's a great point, Dr. Reynolds. It comes down to building relationships. So that's probably, I would imagine, the most effective way to advocate for our peoples. Thank you for that.
And Mark Garofoli is often on here. I don't think he's.
I know, as Dr. Zhang was talking, I was scrolling through Hollywood Squares, but I don't see him on here.
And he may be someone we could approach about that.
Yeah, absolutely. All right, folks, great thoughts. Thank you for your contributions. I think we just two more slides. So just a reminder about ethics and exceptional circumstances. So this may be the time when it seems like we have the least amount of time to focus on ethics. In times of crisis, our attention's really sort of pulled all over the place. And so it's a good reminder that ethics can help us remember what our values are, focus on what's most central to our profession, being of help to others, help us maintain focus on our clients, and then remind us of our role as advocates of justice. And so for my final message, I'll share with you some reminders. As providers, we will make mistakes because we're human. As providers, we may want to help every single person we come encounter, but we have to accept that sometimes that's just not possible. As providers, we cannot know everything and can't expect ourselves to, which is why we continue our learning journey every day. And then as providers, we cannot and should not do this tough work alone. We need and deserve the support of our colleagues and peers in the field. And then when Elizabeth sends this out, there's a last couple of slides, our resources. We've got resources for counselors, ethical resources for social workers, psychologists, and general resources. And I don't have some for, this is a good sort of lesson for me. I don't think I have any on there listed specifically for nurse practitioners or psychiatrists. So that's my homework between now and next time I talk about ethics, to make sure I add to that list. So I need to make myself a note. But thanks for your contributions to the discussion. And I actually meant to borrow Jeremy's plaid buffalo shirt before I joined, and I didn't have time to.
Look at that, just disappointed. Look at that face.
Next time.
Next time.
You're welcome to come in. The door is broken on my office today. So
oh, it's broken. That's great.
Yep.
That's amazing. Awesome. Thank you so much. And thank you for those resources at the end of the slides. I'll make sure to get them. But we just needed one more picture. I was expecting a finale with,
That'll be
animals.
I need to get a animal in a white coat or a buffalo plaid. That's my challenge accepted.
Does anybody have any further questions or comments? This has been a really good discussion as well, so we do appreciate that.
Katie, actually, I had a question. In the legal system, there are precedents that are established by court findings and decisions that are made after a hearing or a trial. And so does that work in ethics also, that there's kind of precedents that are established?
You ask a great question, and I don't know, but I'm gonna follow up on that. And I also don't know if it's different per the different ethical codes in this room. Great question. Making myself a note. Yeah, I don't know if that's what ends up changing the ethical code based on that. I can't say that I've heard that takes place for the counseling, the American Counseling Association, but I will ask.
Thank you so much for the question.
Yeah.
Does anybody else have any questions or any other comments? No? You're gonna get some time back, end it off early. All right, thank you so much again for coming today. Our next session is going to be taking place in March, and that'll be with Dr. Jeremy Hirschler doing case severity. So we look forward to that, and we hope you guys have a really great week. Thank you so much.
Thanks, Steve. Thanks, everyone.
Thanks,
Have fun.
folks.